understand. Because the thing with teams is
And that should be everything. So
Okay, you think it's all gonna work? Is there anything?
your microphone and camera are live now. So if Justin is there, he should be able to hear us. It looks like he's on mute right now, but
Yes, I've got you.
should be good.
And so the sound is really loud.
Yep.
And if you want, I could probably figure it out. Okay, it's just.
So there's a slider down
Right.
here, and you can also do the TV volume
Okay.
as well.
I think I can handle that.
I'll just do about 50-50 on both of them.
And you know how to share screen?
I do.
Okay.
I know how to get in touch with Kenny, but.
Yeah, if you can get in touch with me, go ahead.
Thank you.
Okay. You said Chris is coming up?
I think so.
I'll leave a prop for you.
Okay. Was it in front of me?
That big case where Dennis,
Well, Dennis has testified in several, so.
it was
Oh,
Town
child, yeah,
Town line.
yes, yes.
Town line.
oh, I didn't testify.
I couldn't remember, I didn't know it was a
You
lot of
testified in
people
Burkhardt and then,
who testified.
yeah.
And, comments, I think comments testified.
Taylor's mother and I went round and round and round.
Yeah. Yeah, so I had it first and then Judge Bearden had it again when we got to the trial.
I saw, I got an email yesterday about full release for. I open my mouth, I think it's your case. Roberta sent the email.
Josh Norman.
Yes.
Yes.
I know
Finally,
he's not well.
there was some sensible, common sense thinking in the DA's office.
Okay, good.
So, and he came in and he just, I mean, it's a very sad, that disease he has is horrifying. Some neurological collapse.
Feeling things.
I don't know why I thought. Yeah, case.
He's not the Snapchat.
Snapchat is telling him.
It is, okay. That's how Dennis always.
He's the Snapchat guy, yeah. Yeah. He and Burkhardt started about the same time, which is why I sometimes conflict in my head, but I'm much more familiar with Burkhardt. Obviously.
Are you gonna be able to attend our conference next week? Is it next week or the week after?
Next one.
Next week. The behavioral health and the law conference?
No, I don't know that I know about it.
Oh, shucks. Well, we'll make room if you want to. Do you want to send Judge Gosling the agenda?
I can't, it's short notice.
Yeah, well, just send it to me.
I'll send you the website and that
Okay.
has all the,
Okay,
the agenda information.
okay. Thank you.
That's my
And there's a
email
rumor,
address.
according to the Commissioner Tan, Chief Justice of the Supreme Court wants to attend.
So, yeah, Justice Boggs.
Just about you.
Yeah, okay,
So
yeah. Well, you
I
know,
told him
this is
no.
my only passion as a judge, has been mental health since I started. So. Or behavioral health, as we call it.
I was hoping others would join. Have justice, just.
Right, we're 1 minute from our. I'm not sure we would know. Maybe he knows. It's not. There's Chris. It's just
Good morning.
Did you need me to?
I don't think so.
All right.
I think that the people in Atlanta have.
Okay, fine.
So I think,
Oh, okay.
yeah, so I think that we are, everybody else is doing too.
Oh, so how did the screen change?
So the question is, can we move our, they can't see me. Yeah, I'm trying to figure out what to do.
Oh,
Okay, so tell me if I'm doing something that will make people show up bigger.
Yep.
Is that as far as it goes?
A little bit further. Still going. Yep. It's continuing to zoom in.
Is it? Okay. I just can't tell on this. I just keep hitting it.
Yep, it's continuing. Still zooming.
How's that?
okay, all right. So understand that in addition to the people that are on the screen, the commission folks have a link that some of them are watching.
Yes, a lot of people watch that we don't know about. That's not because they're like.
No pressure.
Yeah, no pressure. I'm not sure I wanted to know that.
Yeah.
Can people on the screen see us? Okay.
Yes,
Okay. Cool. Can you hear us okay?
yes,
All right.
Yes.
Ashley, still on? Do we know if Ashley is on?
I think so. No, it's just the.
Okay, but it's being, is it gonna be, it's recording, yes? Justin?
yes, it's being recorded.
Okay, so she'll look at the transcript, I guess, to do our notes. All right, we're gonna go ahead and start. You can see we have a big crowd in Gainesville. We are lucky to have Dr. Risby, Dr. Wright, and Chris Van Rossum, one of our public defenders. So, and then we have folks on Zoom. We have Judge Darasaw, we have Amy Button from Center for State Government. We have Judge Harris from Macon. We have Marilyn Leak, who's also from CSG. And Ryan, somebody, I can't read your last name because it's too far away. We have Judge Porter and we have Judge Johnson from Fulton County. We have Judge Key. Welcome, Judge Key, a new member. We have some juvenile court members. Ms. Sellers, who's one of our ADAs. Dr. Oliver, also from DVHCD. Who am I missing? Brandon Bullard is supposed to get on. Haven't seen him yet. Oh, we have Herb Cranford, our DA, who was gonna try to get here, but I'm glad you didn't try. Glad you're there. So welcome. Dr. Wright, you have that beautiful picture of you. As well as you in person.
Yeah, this is like my first one, or mainly personal Zoom.
Yeah. Okay, so I think Judge, sorry. It's all right. Can't see. It's all right. Everybody can see your face. Okay. Judge Friesman is supposed to be coming on, so I don't know what's happening in Savannah as far as the weather, but hopefully she has power and we'll be able to get on. And then I think we have everybody else. All right, welcome. We're going to go ahead and start. Okay, good. All right. The first thing I I wanted to do is let everybody know that we do have 2 juvenile court judges now. Judge Key is on. I don't know who the other one is because I don't have my email pulled up. Judge Key, do you remember who it is?
I think it's Judge Philip Jackson, I think. I'm not sure.
And he's where?
If that's what I think it is, he's Fulton, but I'd have to pull it up too to make sure.
Right, I'm Judge Wright. Dr. Wright is saying yes, it is. Okay, perfect. All right, so we're glad to have you as far as this. I wanted to do some updates and then talk about some innovations. We had to switch this meeting around kind of at the last minute because of an emergency situation at the hospital, but we will be scheduling a hospital visit. At the end of this meeting today, one of the things I want us to accomplish is set 2 dates now, between now and the end of the year. So everybody has them down. And I want one of them hopefully to be where we can visit the hospital in Columbus, okay? So that's my goal. And then by the end of the year, we are charged with having some recommendations for legislation and or other things that we can do without legislation. Okay. Any questions out there? All right, so Dr. Risby, Dr. Wright, Dr. Oliver are here to talk to us about where things stand now, what's happened, what are the wait times, what's going on, what efforts, innovations, whatever's happening. Okay.
I'll turn it over to Dr. Wright. She's gonna share her screen and show you guys some information.
All right, did you have anything, nothing to add?
No,
Okay. All right, so good morning again. As we know, Georgia is not unique in being impacted by the competency crisis that is occurring nationwide. So some efforts we have put into place to reduce our pretrial wait list include contract evaluators. We have 10 psychologists, 1 psychiatrist who will be doing contracting work for us, as you know, 2 are Hall County specific. So we have 6 fully executed contracts and 5 in progress. So the executed ones, the majority have started doing evals in various areas of the state. We also are allowing our hospital forensic psychologists and 1 psychiatrist to moonlight nights and weekends. So you may have started seeing some perhaps unfamiliar names or names you know from inpatient to do evaluations on the pretrial list. We're also looking at some efforts that will impact our community forensic psychologists, also that would help to reduce our wait list.
I just say bullets 1 and 2 are new for DBHDD. We have historically not done those 2 things, but the commissioner has given us the green light to look at any sort of outside the box thinking that will address the pretrial wait list.
Good.
So if we look at our pending pretrial evaluations over time, you can see it's been a steady, relatively steady increase since January 2021. We are starting between, as you see, the March and May 1st data points, the top line of total evals, starting to see just a little bit of leveling out. It was April that we started the initiatives with the hospital evaluators. The contractors came on maybe by May or June. So
Well, I think ours just came on, right, in Hall County. So they haven't even actually taken education.
right. So hopefully we will continue to see, if not a decline, well, the goal obviously is a decline. So we're getting to the leveling out point, and hopefully in coming months, as all of the contracts get fully executed and on board, and we look at some efforts for the community psychologists, we will start to see some decline.
So does that mean there are 1,200, almost 1,200 people that are waiting for evaluation?
Adults.
Adults, yeah.
Yes. Actually, it's almost,
It was 1,400.
Is it? I can't,
Yeah.
fold it up across.
Right.
as of August 1st, it was actually around 12. I can double check that.
Okay. Okay.
Those were my August 1st numbers.
But hopefully those initiatives will, we've seen a flattening of that line, and hopefully next time we meet, we can actually show a document.
Yes, that'd be great. Okay, thank you.
Yes, exceptionally great. So another project that we are working on, and I put tentative in all caps because the first meeting is actually today at 12 o'clock. So what we are looking to do, we're starting with Gwinnett County, and it's with state court to look at misdemeanors. These are individuals who have already been ordered for a pretrial competency eval, looking at ways to actually get them the treatment that they really need as opposed to getting them through the criminal justice system for prosecution, because those individuals, excuse me, their greatest need tends to be treatment. They are your sicker individuals. And so this is a project we're working on with Gwinnett State Court, Judge Veronica Cope, the Sheriff's Office, the Solicitor, Viewpoint Mental Health, and Dr. Karen Bailey is heading up that project. And so if we find this to be beneficial, of course, we will like to expand it to other areas. So at some point on the agenda, there was a mention of community-based restoration. So currently
Yes.
we have 59 adults statewide undergoing community restoration. A couple of the challenges that occur with community-based restoration, one is if the individual is appropriate. A lot of the individuals that we opine and are adjudicated incompetent tend to be done so because of mental instability, symptoms of their mental illness. So a lot of times these individuals just are not appropriate for community-based restoration. The second issue tends to be resources. Do they have housing, support system, transportation to get to the restoration sessions? We do, if necessary, we will do virtual restoration, but if a person is unhoused, trying to meet with us to learn about the court system is probably not their greatest priority. So those are just some challenges that we face with community-based restoration, but it is something we are hoping to increase, even if just minimally.
Yeah, we think we can do more community-based restoration. The challenge has been the number of people who could safely do that. And as Dr. Wright said, if the defendant doesn't have housing or community support, if they're not connected with a behavioral health provider to give them the services that they need, then they're not going to be appropriate for community-based restoration. It'll just be a failure. And so, although the commissioner has tasked us to increase community-based restoration, we're really hoping some of these other projects that we're working on, especially the Gwinnett one that just started, to help connect these defendants to community-based wraparound services so that it's even reasonable to suggest community-based restoration. Some defendants are obviously too mentally ill for it to be successful, but there are some, there are more than, we average about 60 a month. We could do more in the community if there were more people that had the wraparound services to make it likely that community-based restoration will be successful.
So they need services and they need some support system, because if they don't drive, they need transportation to make sure they show up every month. And that's been a problem with some of the people that we've had.
And that just
Try to do community-based.
for restoration, show up to the mental health center to
Right.
see the
So that
provider
is-
participate in the
Okay.
program. All right, so
Another question or thought, I think the challenges or barriers to the community restoration is medication compliance. And so perhaps if there were, rather than relying upon the person to take the medicine on a daily basis, if there were longer term options like the shots, that might help create an environment for success.
Right, and that only works for some people and some diagnoses, right, for the
Yes.
injection.
So the biggest challenge with that is the economics of getting them the injection. Number one, hopefully in their court order, it says you must comply with treatment to be part of this community-based restoration. But the Community Service Board has to be able to give it to them. And so in those injections, a cheap one is about $1,200. Some of the better ones are about $3,400 each month. And so some of the community service boards may not be able to absorb that, but there are programs that can be used to help augment that. Various patient assistance programs are available. It's just extra time, extra paperwork, and a busy community service board may not have the bandwidth to get all the additional resources that they need to make sure that the individual gets those long-acting injectables. They have them now where you give them every 3 months, and which will be great for some of our consumers. It's just a matter of who's going to pay for that 3-month injection.
Is that the one that costs more, the 3 month?
It costs more, yeah.
All right, so I will next turn this over to Dr. Oliver.
Oh, can we just jump in there just a second too?
Yes.
One of the things when Commissioner Tanner talked to me last week or sometime recently about this is the jail-based restoration, which we currently is not in the legislation. It doesn't say you can do jail-based restoration, but we are actually doing it in Cobb County. That's the new program.
And Dr. Oliver's going to speak.
She's gonna talk
someone.
to that. Okay,
Yes.
well then, never mind. Go ahead.
Okay, good morning, everyone. Switching over to the hospital side of forensics, you can see here the average wait time for admission once we received the court order. We were trending down and we were very hopeful that our initiatives were working for us, but you can see we're trending back up. We're seeing an increase in the number of females who are adjudicated and competent to stand trial. They were making up about 10% of our waiting list and now at or around 15%. So we're getting more females, which means it's taking a little bit longer for them to get into the hospital system. And part of the reason why I think that and it's trending up again will be the next slide, where you can see the number of orders we receive by month compared to the number of people we're discharging in that same time period. An increase in the number of court orders that we're receiving, and it just keeps going up. So next slide.
Yeah, we'll get more court orders, then we can get people discharged, and so that's wait list is just creeping up for us.
Some of the initiatives that we talked about in our May meeting, I just wanted to give you an update on how they were working. Our FCCs, the forensic community coordinators, going in and doing jail check-ins and restoration sessions with people if they thought were appropriate, and then our own evaluators going back and reevaluating people who were on the waiting list. That has been pretty successful. We've gotten about 75 people off of the wait list in the last fiscal year. So, it's average 6 to 7 per month. So that's pretty significant. Sorry, I thought there was a question. Another thing that we did was just, if we couldn't admit people faster, we were looking at how we were using the bed space for the ISTs. So we started a length of stay reduction challenge for the hospitals for the last fiscal year. And the goal was to reduce the waiting or the restoration time by 20%. 3 of the 5 hospitals met that goal, and they had a reduction of 25 to 44%, which was pretty significant. We are going to continue that challenge, but we're in the process of setting our new goals for this fiscal year. It's worthy of for me to note that the 2 hospitals that did not meet the goal had significant psychologist shortages. And I'm not saying that's the only reason why they didn't meet the goal, but I think that's important to note because we need those people to do the evaluations to get people moving. So.
Dr. Oliver, can you tell us what changes were made in those hospitals to allow that reduction of time?
I left it up to the hospitals to meet with their leadership to figure out where they thought they could improve. So some of it was assigning evaluators right away so that someone's following and checking in with that person. Other hospitals worked on talking with their treatment teams and really making it the focus of every discussion about that person. Because sometimes hospitals can get stuck in, talking about the showers and they were, did this person get along with that person or did they eat? So really just making it the focus of every discussion to see if they can get the person progressing towards competence. I think there were some changes in one of the hospitals in terms of moving psychiatrists around, for lack of a better word, finding one that's more aggressive in medicating for competency versus stability. So there are a bunch of different things that they were doing that I think every hospital is unique, so they needed to come up with their own plan for that.
Thank you.
So this is our slide about the jail-based restoration program. So the RISE program is the Cobb County Jail-Based Restoration Program. It has 20 beds. It opened on January 31st of this year. So as of yesterday, they have admitted 30 people. 13 people have been evaluated and opined competent to stand trial. 4 had to be transferred to a hospital. 1 was suicidal upon arrival, and we thought he needed hospital level of care. So there are different reasons why we'll move them to the hospital if they're not progressing through that program. It's taken, it's a new program, so there have been some growing pains, but I think we have our system in place, so we anticipate the admissions number will go up significantly in the near future. DBHTD hired a new person who is doing data collection, and one of her priorities is to look at the jail-based restoration programs just to make sure that we are using them effectively, that they are a good use of the money that is given to our department. So we have that in place, and we're starting to collect some specific details about every point in time when the program gets the referral, how long it takes before the person's admitted, who they reject. So we're going to have more data moving forward that we can share with you all about the effectiveness. A new development just as of this week is a discussion with Chatham County Jail, currently in negotiation to start a 14-bed restoration program at that facility. And we are having discussions about potentially having more jail-based restoration programs, in probably future fiscal years if we can get the funding for it.
And that was the thing I was just going to mention. Commissioner Taylor said he really hoped that we can come up with a recommendation to add that language to the legislation, the code section right now, because it doesn't mention jail-based restoration. And I think he would feel more comfortable doing all these programs if it actually said that that was an option in the code. So I think that's something we can do as a committee, is recommend that to the full behavioral, whatever it is, reform, innovation group to say this is the language we think should happen. So.
And we're showing some success with the COD program.
Yes, yes.
And we're
Yeah,
excited
and I
about
think
it.
they're probably, you guys have to come up with some ideas about what that should look like, because I think Judge Friesman did mention the Chatham County initiative and what they're looking at, but they have a pretty robust mental health presence in their jail. This would not be something I would want us to try.
Right.
Because we do not have a robust mental health system in our jail, in Hall County, for instance. So I think, you would have to decide what the parameters were for jails that could do it. So, but I love the idea of doing it, yeah.
I have a question. Are we keeping up with which of these are felonies, misdemeanors? Are we distinguishing that criteria in all of these things? But I'm particularly curious about the jail-based and the community-based restoration programs, whether those are misdemeanor charges or felonies.
For the RISE program, we didn't specify if it had to be misdemeanor or felony, but I can tell you every referral that's gone to that program has been a felony case. It is going to be one of the data points that we can pull when we start, doing this data collection, so we can keep track of that.
Great.
As for the community side, it's not something that we track, but it is something that we can pull those numbers.
Yeah.
I say that just because, sometimes if we look at misdemeanors and felonies in two different buckets, it may be easier to take care of misdemeanors than it is to take care of those charged with felonies in more creative ways. But
Also,
it's-
there's in my mind, there's a little more urgency with misdemeanors because they have less time available for whatever's going to happen with them.
right. Agree.
Not as much of a rush because they're either going to be in jail for a while or, there's a long period of time that they could be in jail. So, not that we don't want to give people timely treatment and restoration, but I think maybe they're just a little more time sensitive on misdemeanors.
And I don't think it ended up in one of our slides, but we did discuss some data yesterday for misdemeanor versus felony. And I have my notes in front of me that I think it was for the last 3 calendar years, 14% of the orders that we had for pretrial evaluations were misdemeanors. In that time frame, 19% of the cases admitted to the hospital were misdemeanors. And on our current waiting list, we list by state court versus superior court. So I just pulled the state court cases. So it might be a lower representation of misdemeanors on our waiting list, but it was 12% currently waiting for hospital admission.
Thank you. That's helpful.
That's the next one.
Yes.
So then I think the next slide is our last slide. And because I saw on the agenda, there were questions about wait times. So I thought people might want to see just kind of how long people are staying. So people who are adjudicated IST and admitted to the hospital, it's taking us about 154 days to get them competent on average, and they end up staying at the hospital for 186 days on average. So that makes sense to me. We usually keep people a little bit longer, so like a month, so they don't decompensate before their hearing. But what I thought was interesting, and we'll have to look at more, for those who come in as a pretrial, meaning they haven't been adjudicated incompetent yet, they are taking about 77 days to get competent, but they're staying for 145 days. So I'm not sure what it is that makes us keep them for such a long period of time after we find them competent. Our restoration rates are really good. For those that come in as IST, we're finding 87% of them competent. For pretrials who come in, 79 are opined competent by us. So those are good restoration rates. That's where we want to be. Related to the length of stay for people who are civilly committed to us, you can see the ISTs are civilly committed on average stay about 1,500 days before they're released, and GRIs are staying close to 2,700 days. So that we know is an area where we can improve because our long-term patients, they stay. We can't rotate people through those beds, so it clogs the system. So we're looking at some ways that we can shorten that time frame. Part of that is out of our control, such as delays in getting Social Security benefits activated. So that process is taking a long time and adding significant amount of time for those people. Thought you might be interested in those who are approved for community release, but we're still monitoring them and they still are under court control. We had 32 people return to us in the last fiscal year. And for those people who return, they're staying about 719 days. So it's usually not a quick turnaround. If they have some kind of failure in the community, it usually takes a long time to get them back out in another successful discharge plan.
So I was going to say, to put in perspective, the 32 that return statewide, we, I guess, on average, monitor about 300 people at any given time. So about 10% will return.
Who are the pretrial folks? I think I'm just a little lost on how are they coming into the hospital?
So these are our current process, as these are people who are court ordered to come in as a pretrial. So typical example is the evaluator goes to the jail, tries to do the evaluation, the person refuses, maybe we'll make multiple attempts, we notify the court, and then the court will say this person has to come in as a pretrial because we need an answer to this competency question. Before our waiting list was so significant, we had the option of bringing those people in if we thought observation and treatment might be helpful for them, but we have stop doing that by our own recommendation, and we're only admitting pretrials when there's a court order currently.
So these are folks that an evaluator has not opined
Right.
incompetent, but the judge is still ordering restoration or
And that's basically it's an inpatient evaluation as opposed to an outpatient evaluation. Outpatient being jail or community.
That's new. Evidently speaking.
It happens.
Okay, anybody have questions for Dr. Oliver about this slideshow, or Dr. Wright? Or Dr. Risby, who's here? I don't see any.
This is Philip Jackson. I have one question. I'm sorry I missed part of the meeting. You may have already covered, and I'm new.
Hey, Judge Jackson, nice to meet you. Glad to have
Nice to meet you. My question is, so when they set these programs up in the hospitals, is it just for that county or circuit, or are they moving other people? Can other people from different circuits go in there?
For the hospitals, that people are assigned to the nearest hospital typically. For the jail-based restoration program, RISE is accepting from all over the state. We have a Fulton jail restoration program, and that's only for Fulton County.
Hall County has 2 people I know in Cobb right now.
we have a handful more.
Yeah.
Thank you.
Any other questions? Okay, thank you. I appreciate DVHCD folks doing this in a hurry because the agenda was done fast, and so thank you very much for participating with us. Marilyn is on, and other folks from the council. Is it the Council of State Governments?
Council of State Governments, yep.
I'm not really good with the acronym thing, so I try. But Marilyn's been great in talking to me about what's going on. And so one of the things that has been mentioned is whether there should be early judicial intervention. As we know right now, you get the petition or the motion from the lawyer that says, you know, I want somebody to be evaluated for competency, and there's not much in that. There's not much factually, there's not, you know, it's just sort of a bare bones thing. And that form comes from DVHCD. All the forms that we use, at least here, come from DVHCD. And then the judge signs the order and attaches whatever they can to it and sends it off to the powers that be at DVHCD. The discussion, and I think it's been had in a couple other states, right, Marilyn, about whether there should be early judicial intervention too, because we know that 64% of the folks are found competent. So should we be trying to help figure out if this person really needs an evaluation or if it's something else they need? Maybe they just need medication. Maybe we need somebody good to go talk to them about whether they're willing to take their medication at the jail. And what are the facts? Are the facts that, you know, it's the eve of trial and all of a sudden we aren't ready? I mean, not to cast aspersions on any attorneys, but you know, what's going on sort of would be the emphasis that an early judicial review would have on this to try to alleviate the problem. So I asked Marilyn to talk about this a little bit, and I think we're going to maybe have some more later, but Marilyn?
Yeah, thanks, Judge Gosling. So like you mentioned, so we're taking a bit of a national lens to this. And so we've worked with a couple of different states, and it's interesting seeing these data points because I've seen that chart that that DVHCD showed where it's, you know, the competency evaluations and then the sharp uptick. I mean, I've seen that almost exact chart from multiple different states. So I'm not sure that it makes it any easier, but it is a persistent issue, you know, that other folks are dealing with. And are folks familiar with the National Judicial Task Force? So the National Judicial Task Force, this is a group that it was convened by the National Center for State Courts. It's a group of about 40 judges, court personnel, different folks that spent 2 years developing best practices, policy recommendations for the courts, for state courts. And I bring this up because one of the recommendations is around judicial training and specifically about competency to stand trial and training judges to know when to intervene, when to recommend competency evaluations, and how to prioritize that. And so I wanted to bring that up as an option. And there are some examples of trainings through the Judges and Psychiatrists Leadership Initiative that are focused on competency to stand trial. And I can share with folks following this meeting, the recommendations of the task force, and B, the training modules that I'm referencing, to see if that's something you'd want to consider, recommending for Georgia for the judges across the state. So that's one example. And then I think, you're right, Judge Gosling, a big part of this is early identification. So figuring out how are there ways that you can screen folks to identify and funnel folks into treatment before the issue of competency is even brought up in the courtroom, to potentially divert them out of the competency system in the first place and into treatment services in the community. And I know Connecticut is doing this, and I can send you some examples of how they put this into place. So those are some things off the top of my head about early judicial intervention that I can certainly share with folks following the meeting.
Thank you. We would love that. That would be very helpful.
Judge Gosling, I think I had mentioned to you that I just attended the Train the Trainer on this very subject through the Judges and Psychiatrists Leadership Initiative. So I also have all the training materials, and I'm ready to go train. So that's something I hesitant to volunteer, but I just wanted to add that we had such a great group of people there, but we also had the people from Washington State who are getting fined. Their department is getting fined daily by state court judges for the backlog. And it was like listening to a nightmare horror story. So I'm so glad to see all the things that we're doing, but it was a great training, and I'm like high on Judge Leafman and all of Dr. Vinson from our group was there as one of the trainers. So she and I are ready to go.
Good. Well, that's exciting. I think that's something we need to explore more and maybe make some recommendations about. Then there's some on our next agenda item. It's just an open discussion about what we should be doing with our time. Treatment of misdemeanors versus felonies. And there's discussion whether we should we look at those separately, should or not? Should we just sort of lump everyone together? And I really wanted to hear from the state court judges. So Judge Porter, I think you're it. Judge Bruton was in a trial and is not there, but about whether you think we should have sort of a separate look at misdemeanors versus felons.
Good morning. I definitely think we need a separate one, because the issue we have is we only have 12 months. And so with ours, you're looking at felons, which have much more time. And so bed space for us, for anyone that we would commit, would also almost be counterproductive, because by the time we add the wait time and a 12-month sentence, we can't hold them beyond what the sentence would be. So I think we certainly need to look at ways for that. I have 4 cases that have been on my calendar the past 3 months that have been ruled incompetent. 2 of them, the state has requested additional evaluation because the last evaluation was done in 2021. They're out on bond, 2 of them, and 2 of them are in custody. And so at some point, the clock is ticking with their time, and somebody's gonna have to do something different. So lumping them together, I think it's gonna be more of a challenge.
And the question has come up with some people I've been talking to. So when do you start the time in a misdemeanor case? Does it start when they're arrested? Does it start when they have an order? I mean, when does the time start where you say you only have 12 months? I'm not sure that's even clear. What do you think, Judge Porter?
That's a discussion that we've had with a recent defendant's attorney. Since they have not entered a plea, but they've been waiting for a bed space. It's like, in theory, the state argued that we can hold the case open indefinitely until we get a bed space, because they have not pled guilty or been adjudicated guilty. But oftentimes what we've seen with inmates who are in custody, they will plead guilty so that they can basically get out of jail or move forward with their case.
Yeah.
So I don't think the clock starts ticking until either a trial or plea or paperwork has been initiated.
But then that leads to questions of if somebody's being held for instance, over a year before that happens because they're incompetent, what flags are raised there. So, okay. So that's an argument for a look at misdemeanor cases separately. Does anybody think we shouldn't do that we shouldn't look at that separately?
If I can chime in here, again, from the national perspective. So again, this is another recommendation of the National Judicial Task Force that courts and communities reserve the competency process, including evaluation of competence to stand trial for defendants who are charged with a serious crime. And the recommendation is that you focus on diversion for folks that are charged with misdemeanors and or are assessed at a low risk level. And so a few examples from other states that have done different things for this. So in New Mexico, anyone who is charged with a misdemeanor and found incompetent, the charges are automatically dismissed, and then they're funneling them into community-based treatment services. In California, they have a diversion program for individuals that are diagnosed with a mental disorder and whose disorder was a significant factor in the commission of the charged offense. So again, it's like all about diversion. And then in Tennessee, it's actually not split by misdemeanor and felony. They're assessed at the beginning. And so the folks that are at the highest risk and highest need are then funneled into the state hospital services. And so I'll send you guys, again, we have a little chart with some examples that I'll send you guys if you want to take a look with some, the policy and the different states that we'll share with folks to look at. But I just wanted to bring that up.
Thank you. That's helpful.
I did have a question as it relates to the time. When does this time start ticking? I know it's been the practice of our office that the time starts ticking upon arrest when they're in confinement. But I was a little bit unsure. Well, I'm in the district attorney's office, so of course we're dealing with felonies, and there is more time that is available. However, looking at, I was a little bit unsure about what when Judge Porter talked about plea, that, there was a statement that the state said, the defendant hadn't entered a plea. I was just wanted to know the question, had there been a special plea of incompetency entered by defense at any point? And had that adjudication been made? Because I think that would make a difference too.
Sellers, it has not been made. No plea has been entered. Before that, they have basically been incompetent since the day they entered the jail. And it's just a matter of either restoring them or allowing them to be released. And so literally, other than an evaluation, nothing has been done on their case.
So I think that the law right now in Georgia is that the time frame really applies to civil commitment. And that's when we put on the DBHD when somebody's civilly committed. This is the longest you can hold them because this is the amount of time that they could be in prison for. When it comes to cases that are just,
Trying to get them
restored or even just waiting for the evaluation, I don't think there's any law out there about time. I mean, there's probably civil rights actions that could be brought, but I don't know, Ms. Sellers, for instance, of any case law about that right now. Does anybody have any thoughts on that? So that, I mean, we all think it would be unfair, for instance, to hold somebody that's in jail on a shotgun charge for 10 years, with their mental health issues.
Well, Judge Gosling, the issue that we're having in Fulton and we've seen around the metro areas is that when they are ruled incompetent, the state has not been dismissing the cases. So they literally are sitting on our dockets and nothing is being done with them. The lawyer keeps appearing in court saying, "Judge, dismiss it." I said, "It's not my case. I don't have the authority to dismiss it." So we have at least 5 cases on my docket that the state, I've talked to judges in the municipal court, in other counties within Metro, and I don't know if they've decided they're not going to dismiss them, but I can tell you that in the 5 or 6 years that I've been working in this mental health court, we have never, ever had a civil commitment of anyone whatsoever.
Wow.
I might add to that, what the code says for misdemeanors is under Title 17 is that for a misdemeanor, and this is where, and I'm going to jump in, I was saving this for later, but this seems appropriate. One of the things that we're looking at on the involuntary commitment subcommittee is that under this misdemeanor statute, it says the court has the option dismiss the case and we're done. You null process, we're done. And the person just is out, or you refer it to the department, so that's DBHCD, for civil commitment through the probate court. And that's where everything lands. And from what I understand and what from Judge Porter is affirming is that that's the process that never happens in these misdemeanor cases, because I don't think anyone knows who the department, well, they know who the department is, but there's no process beyond what the code says, send it to the department. That's where things get stuck. And so it never gets to that civil commitment, and the civil commitment apparently has to go through the probate court. So we were looking at, well, why does it have to go through the probate court, or do we need a process, or do we need to broaden it so it could go through state court and the probate court? And there are a lot of different factors in that, because I understand if you're the solicitor or the district attorney, do you just want to drop the charges and null process it because the person's not getting any help? So you're stuck in this limbo of what to do. And so that may be something we want to look at. How can we fix that? Either there's a mechanism there, it's just not being used, and do we expand it so that the state court judge or the superior court judge handling the misdemeanor can continue that through their court?
Yeah. So we need judicial education on that if we decide that's sufficient in the code section.
But we need a process too from DBHCD. We need policy on that because there is none.
Okay. So that's something we say, that's a difference between misdemeanors. There's already a path. It just needs to be fleshed out.
Right.
And also that path is available to nonviolent felonies. So if there's a low-level felony, we could also, the same thing that Judge Harris mentioned, dismiss the case, null process the case, and transfer that case to probate court or to the department for to a determination of civil commitment through probate court. But Judge Harris is spot on. Where does that process happen? And I know we've had conversations with Judge Johnson here. And so in our probate court here in Fulton County. But again, that process, like Judge Harris said, is not
there's no clear track.
A clear track, yes.
Yeah. And the other thing that you have to consider that what I've found is real sticking point is you're adding in an extra step, because what the code says is petition the probate court. So that means the department has to get an attorney, have another evaluation, bring it to the probate court. And I often wonder do we need all these steps in between? You know, we've got, I say this within this group, but I know what advocates would say, but I'm just saying in this group, we've already got an evaluation. If we've got it right then, if we act on it at that point, do we need all these extra steps that are required under the code? Because everything defaults back to Title 37. And you have to start, and I see Dr. Rigsby's shaking his head because he knows you have to start all over. And that means they've got to get a lawyer, or the CSU's got to get a lawyer, or whoever's going to handle it. So then you're back to money and more time and et cetera. So
Is this something that may be right for us to suggest a pilot project or two in the state so that you could develop
right.
You could actually be trying some stuff.
Yeah. And we're actually looking at that on our committee as well, trying to figure out a pilot project or doing something like bringing an AOT program, because this would really fit the assisted outpatient treatment program. If you were setting up a lot of outpatient treatment, because some of these misdemeanors, probably a large percentage of them probably could be done outpatient if they had the right supports. I'm thinking, I'm not the doctor, but I think that could probably be handled as opposed to stacking them back into the hospitals, or at least a short stay at the hospital, then out into the community. So
have a robust CSB to handle it. So
right.
Part of the beauty of doing project, which I love, is to find out what works, what doesn't, what you
right.
need.
And I'll also say, and Marilyn can kind of help with this, one of the things that is helpful, and I can see it, is we have the sequential intercept model. We've modeled it out for Georgia. Don't we have that, Marilyn?
For the state, I think I've seen local sequential intercept models, but I don't know that I've seen one for the state of Georgia. But yes, there's certainly
they are out there. And if you take that, and a lot of what they're talking about on the national level is they're looking early on. I mean, they're looking at arrest. So person comes in, they are arrested. You have a jail evidence-based evaluation at that time, and you look at that person and decide, does this person need treatment? Is this person a candidate for diversion? So you're back all the way to the bond stage. So they come in, first appearance, bond, where there are all sorts of places that you can divert within the system. So if you look at all of our entry points on that sequential intercept model, you can identify areas where the court could intervene to divert this person over to mental health treatment. And it seems to me the misdemeanors are probably the ones that work the best or the easiest to identify that way.
Well,
so we'll just going back to the judge having the power to null process the case or dismiss it. I think at least the way the competency statute's written right now, so there has to be two findings. First, that the person is incompetent in the first place, and then second, that they're not restorable. And I think that still requires the defendant to be transferred into DVHD custody. I mean, typically we get a 90-day report where they're making that determination whether or not they think there's a substantial likelihood of them being restored, and then they can hold them for an additional, I think, 9 months.
right. So we're getting here.
So maybe we want to look at changing that language where we know, at least for misdemeanor cases, if there's simply the finding that they're not competent, the judge would then have that authority. Because as it is right now, I think even if they're not competent, you're still waiting on them to go into some sort of DVHD services to see whether or not they're restorable. So I don't know that
Right.
it's set up in a way to be
To
able to
allow
move
that?
cases.
Yeah, Judge Harris, you were quoting some law too. If your subcommittee could work with us on what would be an option for misdemeanor cases, and we'll all look at the law. That definitely is an agenda item for the next meeting, I think.
And I believe Judge Johnson had a question. Her
Oh, Judge-
hand had been raised and.
Judge Johnson, did you have a question?
Good day, everyone. Just as we were talking about pilot programs, we need that judicial the judicial determination of incompetency. And if probate judges were allowed to deputize judges to be more present or at some stage with the authority of the probate court to make those on the spot determinations to move treatment forward, that may be helpful as you talk about a model of a pilot program to move things along and eliminate steps of probate court. Maybe we can sort of put probate court in the places that it needs to be, or empower those that are making the decisions, put them in the process, and usurp the probate court process. Just a thought to have someone else be more empowered to make that judicial determination of incompetency in the moment to move the matters forward.
Okay, well, I think that's definitely something that Judge Harris can bring back to her subcommittee if she's working with Judge Harris. You think so? Yes, okay. She's shaking her head, yes. She's muted, but.
Sorry, we'll look at all that.
Okay, that's
Judge
good.
Harris, can I add that one of the things that the colleagues that I've worked with have said, though, when you have someone who has been determined incompetent and for the judge to have the authority to dismiss, it's almost like without a plan of action or treatment, most judges I know would not sign their name to dismiss a case against someone who is ruled incompetent without a safety net or a plan of action going forward. And that's the exact issue that the state has. They're not prepared to dismiss it, so you literally have these people sitting. So unless DA can give us some sort of coverage, protection, assistance for these defendants who have been ruled incompetent, it's kind of like everybody just sitting at a standstill. So I don't know what that would look like for DBHD. I think bed space certainly should not be the option. It should be some sort of community-based treatment that someone is able to send them to immediately. And what we have been doing in Fulton is oftentimes the judge has released them from jail rather than letting them sit there indefinitely. And that's the risk also, because you tell them to go for treatment, go for medication, but oftentimes they reoffend and are rearrested.
And I agree, that's absolutely the problem.
Yeah, homelessness is a problem everywhere too. I mean, I know that that's a problem here. I'm sure it's a problem in Fulton. I mean, they don't have anywhere to go. We have essentially no homeless shelters up here, so.
Oh, I'll just mention one of the things we're looking at here is our CSB is now in the jail here, which is great. That makes it so much easier. But one of the things we are looking at doing is, in order to get them out of the jail, we're making mental health outpatient treatment a bond condition and monitoring it. So I can't say if it's working or not because we're just getting started. But that's one of the things that we're looking at. This is just in state court for misdemeanors that have been identified. And so because we have our CSB in the jail, we have a warm handoff. It's a smooth transition. I'm not sure how it would work if we didn't have that. In fact, we've been talking about it now before and couldn't quite get it to launch, but now we've got everything set up, so we're moving forward. So I'll keep you posted on that. But that's one of the things that we're looking at. And so the idea is that they're going to monitor it. If the person stays, what they have agreed is the public defender's office and the solicitor's office have agreed. If they'll stay on the medication, they don't care about prosecuting so much a criminal trespass over and over again. They're willing to null pros, but they want to make sure the person's going to engage in treatment for a stated period of time. So that's.
Do you have a solicitor on your subcommittee?
I do not, and I sort of begged for a state court judge, but I wasn't given one, so I'm going to get one, Judge Porter. Would you like to?
Even from our committee.
Or I'll
be
tag
happy
up.
to do so. This is
Look, it
that is
works.
near and dear to my heart. So we definitely be in until I can tag someone else in.
Great.
I think it'd be helpful to get a solicitor somewhere too on one of our subcommittees. So.
Yeah, definitely.
Okay. All right, we kind of covered a lot of the things that were listed under restoration. And the probate court innovations, I think Judge Harris has given us several good things to tell us about. I wanted to hear from Judge Key and Judge Jackson about juvenile court issues that have come up, and anything that you, did we lose Judge Key?
I think he sent a chat message that his battery was going down, power.
Oh, okay, okay. Judge Jackson, anything you want to say about juvenile court that we should be looking at on this subcommittee?
Like state court, you might want to have a separate committee for juvenile court because the law is so different. One of the things we do have advantage of, we have DFACs. Sometimes we can use them. But some of the issues, time limits are important too. So I'm probably thinking, since I just got on it, I probably need to get with Judge Key and maybe we can reach out to see what you're doing. But I think you probably need a subcommittee just for the juvenile court.
I think what Commissioner Tanner envisioned by suggesting that you be part of this is that, you know, we incorporate you in our stuff. So if you, I don't know that two of you need to be a subcommittee all by yourself, but so if there's a way for us to come up with a list of things, these are the things we think should happen, you know, code suggestions for changing the code, pilot projects, things that could be done. I mean, I was thinking, for instance, well, I'm digressing. So juvenile court, you know, would be part of their own little section, but they would be part of the section. So you and Judge Key get together and talk about what you want us to do.
All right. And we just got a point. So probably that you sent us your information in the tape, but I hadn't had a chance to review it. I don't think Judge Key had.
Yeah, we're just this week or something. So we're excited to get involved.
I like the idea though about maybe having concurrent jurisdiction as opposed to doing for civil commitment as opposed to sending it to probate court though.
Okay, that's good.
I like what Judge Harris said. It might keep it simple, better than deputizing, maybe just concurrent jurisdiction. Just for
yeah.
Ms. Gosling, can you hear me?
Yes, is that you, Judge Key?
Yeah, I'll just say very quickly, I was logging on my phone. Yeah, I'm going to talk to Judge Jackson about this. I was thinking we may try to set up a listening session and invite all of our judges to it by Zoom call and get their thoughts around the state. But beyond that, I agree with everything that Judge Jackson said.
Okay, good. Well, one of the things that when we talk about, for instance, the whether we want to have early judicial intervention, is when I looked at the forms from DBHTD, I thought there might be a way to just tweak the forms. And that would give judges, we'd have to tell judges that we've tweaked the forms and they'll look at the forms and it says maybe you have the authority to have a hearing on this and these are some things you should look at if you're having a hearing. And it could be the option that you brought up before, Chris, is that if somebody, if a defense lawyer says, I don't really want to talk about that in open court, I want it to be ex parte, they would have the authority to do like we do with getting money, where, you know, you say, okay, it's sensitive, it's about the facts of the case, then we have an ex parte. But in a lot of cases, it's not. It's just that, you know, they're spitting at you in the jail and they won't talk to you or something. That really isn't necessarily something that is secret, right? The jail knows all about it. Sure. So if we And that's good, but if there's some lawyer that can't give us any information, they kind of stumble around, you go, maybe this is not, maybe it doesn't need to go on to this whole process and bog down the list. Anyways, that's just a thought I had that we can explore later, I think, especially after Marilyn gives us some more information about other places. Marilyn, can you tell us about the person that you hope will come and speak to us at one of our future meetings?
Yes. So his name is Dr. Feeks. He runs the Tennessee, let me make sure I get this acronym correct. The Tennessee Department of Mental Health and Substance Abuse Services. And they're doing a ton of really interesting work, including they've been doing outpatient competency evaluations like since the 70s and have a ton of data on what works and what doesn't. And I think have a lot of really interesting findings that they could share with you on what they've done in Tennessee and what's worked. We're working on a similar project in Kentucky, and he did a presentation to them, and it was very interesting. And they're doing some work around managing folks with developmental disabilities, and they've really been able to make a big impact on the waitlist for competency evaluations. And so I hope that we can get him to come speak to you all about what they're doing in Tennessee, at the next meeting, and can give you more details. And I will, in the meantime, we have a little one-pager we've developed with some kind of key points of what they're doing. So I'll share that with you all kind of as like a little teaser so you can read about it. And then hopefully we can get him to come talk and you can actually ask him some questions and hear more about what they're doing in Tennessee.
Yeah, I was hoping for our next meeting that we could have him present so that we can hear what innovations they're doing in Tennessee. Does that sound good to everybody to have him come? DBHD folks say yes. Nobody's saying no, so that's good. All right. Okay. Anything else? This is the time to bring it up. If you have some other burning desire to do a project or think we should be looking at something else, have some great expert you want us to get to come talk.
Marilyn, could you send us a sequential intercept model from one of the counties, or maybe two, where you've got a state court and another one where you don't have a state court, if you have those?
Yes, I will see what I can find.
Athens did it for their co-responder project, so they have one.
I know Athens and Fulton and Chatham I've seen have pretty detailed maps. So I'll see what I can dig up and share with you all.
Okay. Anything else? Because the next step is going to be just to talk about when we should have the next meeting. So we're going to be done really early, and we had lunch provided, but you may have to take your lunch and take it with you or something. What is a good time for us to meet? I mean, I feel like we should allow between an hour and 2 hours for a meeting. If we obviously we go to the hospital, we need more time to tour, but so what is it? Is it Wednesdays? Is it Fridays? Is it, I don't know if you've heard when you've done this before, what works best for folks?
I know that 2 other subcommittees typically meet on Thursdays, so that would be a good day to select.
Yeah, Thursdays are bad anyways for me. I can be of accountability court stuff all day long, so that's not, Thursdays are not good. You tell me, folks on the call, just speak up.
Friday's probably better for me.
What?
Friday's probably better for me.
Fridays, okay.
Friday, I have mental health court. And so my days are probably Tuesday, Wednesday, and Thursday are probably my best days.
Okay.
Well, in the afternoon is better for me.
Afternoon is better.
Yeah.
Judge Porter, what about afternoon versus morning?
On a Friday afternoon, you're gonna be hard pressed to have me on a meeting.
No. Not Friday.
Not a Friday afternoon, but I'm saying if we do it during the week.
The afternoon, move it to a different day.
During the week, we're good.
Okay. Judge Harris, what works for you?
Afternoons are better for me.
Okay. Judge Jarasaw?
I was finding the unmute button. Yeah, afternoons are better. Wednesdays, Thursdays no good for me. But afternoons on Wednesdays, I'd say late afternoon, like 3 o'clock.
Okay,
Yeah, it works.
okay. Ms. Sellers, what about you?
I think Wednesday good days. I'm just at the mercy of hearings and things scheduled. So
Yeah, okay. Well, let's shoot maybe for a Wednesday afternoon for our next couple meetings. And when we go to the hospital, we may have to send out some sort of poll. My thought is that the next meeting would be a regular meeting.
Okay.
And then we go to the hospital later. Okay. If people want to go, I mean, there was a discussion about wanting to go to the hospital. If you decide you don't want to go to the hospital, just send me a text or an email or something and say, gee, let's take that off our agenda. We don't care about going to the hospital. Okay? So we're going to try to do that. I'm not going to set the dates today, but I'm thinking that we do one late September or early October, and then another one before Thanksgiving, so November or early December. We don't want to get too late because, you know, then it's crazy. What do y'all think? Early October, maybe early October?
yes.
All right. We'll look at some dates and send out some options for a Wednesday afternoon that works. And, you know, if we're not going to go to the hospital, is everybody good with Zoom, or do you want, I mean, we can try to meet in Atlanta again. I know nobody wants to drive to Gainesville, but Zoom is fine with me if you are good with it. Sometimes we don't have as much conversation, maybe, you know, if we're doing Zoom, but it's convenient. Thoughts?
It could be both ways. Hybrid with the Zoom option. Depends on
Right, okay.
better for calendars.
If you're willing to drive to Gainesville, that's easy for me. I can arrange it. If we have to go to Atlanta, then we have to get Atlanta folks involved in where we can meet. But okay, you're not talking too much. Well, South Georgia, Judge Daresai, you want to do Zoom?
I'm willing to drive. Zoom does work for me. It's always available, but I'm willing to drive.
Okay. Okay. All right. Well, we'll sort of leave that in there for the moment. I'm not sure I want to be in Atlanta at 5 o'clock on a Wednesday, but so Zoom might be our option. Okay. All right. Well, then I think unless somebody has something else.
Judge Harris, can I get your contact information? I have a question I need to ask you once we get off the call, please.
I just sent it to you in your chat. Did you get it?
Let's see. Oh, it's not showing up.
Right. It's I'll give everyone my cell phone number. My cell is 478-361-2300.
Okay.
And Judge Gosling, I just want to go on record saying that I am looking forward to visiting the hospital, to touring one of the hospitals, one of the regional.
Thank you. Okay, so we do want to do the hospital. Ashley mentioned to me that we have, you know, we have people watching that aren't part of our committee. And so but they don't have access to ask questions. So
if anyone calls me and I don't know who you are, I may not answer.
Right. And so, but the question is, Ashley wants to know if we want to change the format of our meeting. Unfortunately, I don't really understand the options. You're not talking to the most tech savvy person here. So maybe we can talk about that, and we'll send out some emails about that, what that would look like if we change the format so that they can ask questions. Because that may be helpful to us to get some more feedback. On the other hand, I don't know how many people are watching, but we don't have time for 40 questions. So. But we can talk about that too, okay? All right, good. Well, we'll plan 2 meetings, one hospital, one at 3 o'clock on a Wednesday afternoon. probably Zoom and Gainesville, and you can drive to Gainesville if you want. It's a beautiful city, or you can not drive to Gainesville. Okay, and Marilyn hopefully will be able to get Dr. Tennessee.
Dr. Feeks, Dr. Jeff Feeks, yes, we'll reach out to him.
All right. All right, thank you for participating, even though down there where there's bad weather, so be safe.
Thank you.
Judge Gosling,
Yes,
if you can get me that date as soon as possible, we'll arrange my calendar. There's a good chance I could probably show up.
okay, we'll try to do it really soon.
Okay.
Thank you.
Thank you.
Thank you.
I like the initiative.
Right, I think yes, I do. I think we got a